Margin guidelines for skin cancer. In case of non-melanoma cancers, there is horizontal margin for BCC, basal cell carcinoma and squamous cell carcinoma low risk we take margin 4 to 6 mm, and for high risk we take margin of 10 mm. Merkel cell carcinoma are all high risk lesions, so we go for directly for 10 to 20 mm margin. In case of sarcoma, if it is low risk we go for 10 mm margin, and if it is high risk we go for 20 mm margin. In case of vertical margin, if the lesion is till dermis we go till the fat layer. If the lesion includes the fat layer we go till the deep fascia. If the lesion involves deep fascia we go till the muscle, and if muscle is also involved we go till the cartilage or bone. So we follow this order. Comparatively, in case of melanoma skin lesions, if the melanoma is in situ, we go for 5 mm margin. If the size of the melanoma is 2 mm, we go for 10 to 20 mm margin. If the size is more than 2 mm, we go for 20 mm margins. Coming to the basal cell carcinoma. Basal cell carcinoma is the most common cancer worldwide. 80% of the non-melanoma cancer origin is stratum basal. Local recurrence is more common than metastasis. Therefore, there is limited role of lymph node biopsy. Most common site is head and neck, which accounts for 85%, followed by trunk. Risk factors are sunlight. Here, sunlight during childhood and adolescent age is more important. Moreover, intense intermittent UV exposure is much more dangerous compared to the continuous exposure. Fitzpatrick skin type 1 and 2 are also risk factor. Any family history, HPV infection, immunodeficiency, radiation, arsenic and hydrocarbons are also risk factor. The basal cell carcinoma is also associated with Gorlin syndrome, xeroderma pigmentosa, Behçet syndrome and nevus sebaceous. We can remember nevus sebaceous that there is 2.5% increase in malignancy per year, 1.1% chances for BCC and 0.57% chances for the squamous cell cancer. Now coming to the BCC subtypes. The first and the most common subtype is the nodular subtype. Here there is classic pearly papule with overlying telangiectasia and rolled borders. As it grows, there is central ulceration which develops. Most common site is the face, where most common is cheek, nasolabial fold, forehead and eyelids. The second most common lesion is the superficial basal cell carcinoma, accounting for 15%. Site most common is trunk and extremities. The lesion is sharp, circumscribed, scaly and erythematous, multicentric patch. This multicentricity leads to incomplete excision. Moreover, this type of BCC is also misdiagnosed as fungal infection or eczema, leading to mistreatment. Now coming to the morpheoform basal cell carcinoma, it is the most aggressive type. Here there is firm, shiny, smooth, indurated plaque within the scar. This is the plaque. It spreads subclinically. There is extensive local destruction underlying. Diagnosis is by full thickness biopsy. Coming to the surgical excision, you can go for primary surgical excision. If the lesion is low risk, we can go for 4 to 6 mm margin. If it is high risk, we go for 10 mm margin. NCCN does not recommend about the margins. It recommends the post-op margin assessment and identification of clear margins, which are more important. In cosmically sensitive areas, we can go for the most micrographic surgery, where we have the complete margin control, and simultaneously we are checking the margin clarity with the frozen section histology. We can also go for the destructive therapy such as the radiotherapy, electrodissection and cryotherapy. Radiotherapy is particularly important in case when there is margin positivity. We can also go for medical management, for example, imiquimod, topical 5-fluorouracil, and SHH pathway inhibitors. Coming to the follow-up, we have to go for complete skin examination plus minus imaging for 6 to 12 months for the first 5 years, followed by annual examination for life. There is 10 times increased risk of BCC, and there is also increase of other skin lesions such as the squamous cell carcinoma or melanoma. Now coming to the squamous cell carcinoma, it is the second most common non-melanoma skin cancer. Now coming to some pre-malignant lesions which can lead to the squamous cell cancer, such as the first lesion is the actinic keratosis. It is precancerous. There is 0.60% risk of transformation at 1 year, which increases to 2.57% at 4 years. 65% of the transformation is into the squamous cell cancer and 35% to the basal cell cancer. Actinic keratosis do not have high Actinic keratosis has high probability of spontaneous resorption. Treatment is by cryotherapy. Now coming to the Bowen disease. Bowen disease is the squamous cell carcinoma in situ. There is 3 to 11% risk of cancer. They are flat, scaling and pink lesions and is entirely in dermis, that is in situ. The other lesion is erythroplasia of the querate. It is squamous cell carcinoma in situ, specifically on penis, but it is different from the Bowen disease as there is 30% chances of invasive cancer, and of which 20% will have metastasis. Now coming to the keratoacanthoma. Keratoacanthoma originate from the hair follicles. They are sharp, circumscribed and rapidly enlarging papule with keratotic cores, which can spontaneously resolve after months, but it can also transform into the squamous cell carcinoma. Multiple keratoacanthoma can be seen in Ferguson-Smith syndrome, Muir-Torre syndrome, Witten-Zach syndrome, and Grzybowski syndrome. Marjolin ulcers. Marjolin ulcers occur in burn scar, venous ulcer, arterial ulcer, osteomyelitis, fistula as well as trophic ulcer. It can develop in any ulcer. Most commonly it is in the lower extremity. The latency period is 29 years. There is high rates of metastasis. 32% of the patient have lymph node positive at presentation and 27% has distant metastasis to liver, lungs, brain and bones. Risk factor for the squamous cell cancer is cumulative UV radiation, fair skin types 1 and 2, HPV infection, immunosuppression, albinism and xeroderma pigmentosa. Diagnosis is by full thickness biopsy. NCCN recommend sentinel lymph node biopsy in very high risk cases such as recurrent multiple high risk factors. In case of low risk cutaneous SCC lesions, we go for 4 to 6 mm margin, and in case of high risk cutaneous SCC lesions, we go for 10 mm margins. We can also go for destructive therapy such as radiotherapy or cryotherapy when surgery is contraindicated, or when there is high risk lesion along, we can add radiotherapy along with the surgery. In case of medical management, we can go for topical 5-fluorouracil ointment or trichloroacetic acid, which this 5-fluorouracil is specifically useful in HPV associated multifocal cutaneous squamous cell carcinoma lesions. Compared to the coming to follow up, 13 to 50% patient will again develop squamous cell cancer in 5 years. Therefore, we have to go for skin examination every 3 to 12 months for the first 2 years and 6 to 12 monthly for 3 years, following which we have to go for skin examination annually for life. Now coming to melanoma. Melanoma originates from melanocytes which are lying in the stratum basal. It is 5% of all the skin cancer, but it leads to 75% of the mortality of the skin related cancers. Risk factor for melanoma is UV exposure, history of sunburn, history of cutaneous melanoma, melanocytic or dysplastic nevi, tendency of freckles, fair eye, hair or skin color. In examination part, we have to focus on A, B, C, D, E. Asymmetry, irregular borders, multiple colors, large diameters and evolution of the lesion. There are two molecular pathways through which the melanoma develops. The first is the BRAF proto-oncogene and the second is NRAS proto-oncogene pathway. This BRAF pathway, there is nevus prone pathway. It occurs in young age patient and there is no history of sun damage. The lesion is superficial spreading melanoma. Here, BRAF targeted therapies are available. The other pathway is NRAS pathway, which is associated with chronic sun exposure. It occurs in older individuals on sun exposed areas. Clinically, these lesions are more aggressive and there is no targeted therapy available. Coming to subtypes, superficial spreading subtype is most common. Here, there is a radial growth pattern. This is superficial spreading subtype. The other is the nodular. There are dark dome shaped lesions which mimic blood blisters. There is vertical growth pattern. The third is the lentigo maligna. It is black, more common in black persons. Black or Fitzpatrick 5th, 6th skin subtypes. They are more common in palms and soles and in undernails. Coming to A, melanotic subtype, which lacks pigment and is very difficult for the diagnosis. The fifth type is desmoplastic, which is very rare and is aggressive locally. Diagnosis is by clinical examination and dermatoscopy. Ultrasound of the lymph node basin can be done to exclude the lymphogenic metastatic spread. CT or MRI has to be done in case of high risk patient or there is evidence of metastasis. Management is by wide local excision of the primary disease. If the disease is in situ, we have to go for 5 mm margin. If the disease size is 2 mm, we have to go for 10 to 20 mm margin. If the size of the lesion is more than 2 mm, we have to go for 20 mm margin. Now coming to rare skin cancers. The first is the Merkel Cell Carcinoma. Merkel cell is a mechanoreceptor. These cancers are very rare and highly aggressive. Risk factors are UV exposure and immunocompromised state. Clinically, these lesions are rapidly growing red-violet lesions. They are solitary, cutaneous or subcutaneous lesion in the sun-exposed region. According to NCCN guidelines, we have to go for 10 to 20 mm margin, wide local excision. Large margins help here to include the microscopic satellite metastasis. Otherwise, the prognosis of the Merkel cell carcinoma is very poor. Dermatofibrosarcoma Protuberans. This is a rare cancer. It affects the middle-aged adult, age group 30 to 50 years. Origin is the dermal fibroblast. They are slow-growing firm fixed plaque or nodular lesion. They are flesh colored, pink or brown. Diagnosis is by full thickness skin biopsy. Management, we have to go for 20 to 40 millimeter lateral margin wide local excision. If the margins are still positive on histopathology, we have to go for radiotherapy. We can also give emanative mesylate as neoadjuvant or as adjuvant in case of unresectable diseases.